Welcome to Wisdom Radio. I'm Dr. Rusty Hofmann, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
Welcome to today's deep dive. So imagine a patient rolls into your ER. They have an active, non-variceal GI bleed.
Right, the clock is ticking.
Exactly. Pressures might be a bit soft, and your multidisciplinary team is just, looking to you for the next step. And the imaging choice you make in that exact moment dictates whether this patient heads to the cath lab, the OR, or just back up to the ward.
It is arguably one of the most high-stakes triaging decisions we make.
Right.
Non-variceal GI bleeding is still the most common GI diagnosis leading to a hospital admission in the U.S. And yet, if you look across the landscape, the protocols are just, they're all over the place.
Oh, absolutely. You look at the existing guidelines from the ACG, the ASGE, the ACR, and they frequently disagree on the ideal sequencing. It creates this multi-society guideline noise that can be frustrating when you're just trying to map out a clear protocol for your hospital. So today, we're cutting through that noise.
Yeah, we're doing this by synthesizing two highly practical modern sources. First up, we have the newly published ACG and Society of Abdominal Radiology Joint Consensus Statement. That's the Singupta's paper from Radiology 2024.
Right, the harmonization one.
Exactly. It's a direct attempt to harmonize cross-sectional imaging protocols. And second, we're pairing that with a 2025 Duke University update by Benvenuti and colleagues on provocative mesenteric angiography. It gives us the hard modern data on the ultimate break glass procedure when you're in the cath lab and standard imaging has failed you. Our mission today is to map out exactly when you should use which imaging modality and pinpoint when IR should step into the pathway.
Perfect. Let's establish a clear baseline for everyone first. The imaging debate usually boils down to a choice between two mainstays. You have the CTA and the tagged RBC scan.
Yeah.
And I like to frame that overarching diagnostic dilemma kind of like this. Choosing between a CTA and an RBC scan is essentially like choosing between a high-resolution satellite photo taken at one exact moment versus a low-res security camera that runs for an hour.
That's a great analogy.
Yeah, one gives you anatomical perfection, the other catches the intermittent culprit, but both have blind spots if you use them on the wrong patient.
Exactly, and that is a framework for the lower GI bleed paradigm shift we're seeing in the Singupta consensus. Because for years, there's been this push-pull in the ER between ordering the CTA versus the RBC scan for overt lower GI bleeding.
Oh, constantly.
Right. But this new consensus statement plants a definitive flag. CTA is now strictly positioned as the first-line imaging study in hemodynamically unstable patients, and it's a strong consideration for stable patients with a high clinical suspicion of active bleeding.
Let's talk about why CTA wins that first-line spot, because the physiological trigger you're hunting for with a CTA is active extravasation at that exact second. The contrast bolus hits the mesenteric vessels.
Right.
And with modern multi-detector scanners, the sensitivity is incredible. We are talking about detecting bleeding rates as low as 0.1 milliliters per minute.
It translates to about an 85 to 90% sensitivity, 92% specificity, and an overall accuracy of roughly 95%.
Wow.
But you also have to consider the flip side, right? Like, what happens when that CTA is negative? Historically, a negative scan felt like a diagnostic dead end. You contrast loaded the patient and didn't find the bleed.
But the Singupta paper reframes that, which I love. They highlight the prognostic value of a negative CTA. It's not a failure. It is an actionable piece of data for your team.
Exactly. Statistically, a negative CTA significantly lowers both your rebleeding rates and your subsequent intervention rates.
Because it tells you the patient has likely stopped bleeding.
Exactly, at least temporarily. So you can safely transition your focus. You move away from rushing them to the Angio suite for this blind, desperate search, and instead you just focus on supportive care, resuscitation, and setting up an elective endoscopy.
That makes perfect sense for CTA. But okay, this brings us to the TAG RBC scan, and I really have to push back on its utility in modern practice.
Okay, let's hear it.
Well, the guidelines suggest reserving it for hemodynamically stable patients after a negative colonoscopy, or, when CTA is unavailable or contraindicated due to renal issues. Now, I understand the physiological appeal. You tag the cells, they have a long intravascular half-life, and you can dynamically image the GI tract for hours.
Catching those microscopic bleeds.
Right, down to 0.04 to 0.1 milliliters per minute. But the Singupta paper points out a glaring issue with localization.
Oh, yeah. The localization error rate is the Achilles heel of the planar RBC scan.
The data cited in the consensus shows a 10 to 33% incorrect localization rate. When you compare overall accuracy head-to-head, one study showed the RBC scan sitting at a dismal 55.4% accuracy compared to CTA's 96%.
It's a huge gap.
If you're an IR physician prepping for a procedure, a test that gets the location wrong a third of the time is a liability. Imagine getting a scan that says the bleed is in the ascending colon. You get arterial access, you navigate all the way into the SMA, and it turns out the bleed was actually in the descending colon and the tracer just pooled on the right side.
Right, you just sent your cath lab team down the wrong mesenteric vessel based on bad directions. And I completely agree. The consensus authors acknowledge this danger. The standard planar RBC scan can misdirect you because the functional activity of the tracer can be confused with so many other things. You get physiologic uptake in the ureters, penile activities, or even just a non-enteric hematoma. The functional blob on the screen doesn't give you the anatomical context.
Right, so how do we mitigate that if we're forced to use an RBC scan on a stable patient?
Well, the way to salvage the utility of the RBC scan is by utilizing SPECT-CT. You have to cross-reference that functional tracer uptake with anatomical cross-sections.
But SPECT-CT isn't universally available.
No, especially if you're dealing with an off-hours bleed on a weekend. So the rule for mapping out your hospital's protocol is this. Rely on CTA to give you the vascular roadmap. Reserve the RBC scan for the stable patient with an obscure intermittent bleed where you have the luxury of time to wait for a positive signal. And ideally, ensure you have SPECT-CT to confirm that localization before you puncture an artery.
All right, let's transition and move proximally up the digestive tract. We're moving out of the colon and into suspected small bowel bleeding. This requires a shift in how we think about lesion morphology. The consensus statement firmly elevates CTE, so CT enterography, for this region.
Yeah, the small bowel has always been the black box of GI bleeding. Endoscopically, it is incredibly difficult and time-consuming to reach with push enteroscopy or double balloon techniques. And radiographically, your standard abdomen and pelvis CT protocols frequently miss mural-based masses. CTE is specifically designed to optimize the evaluation of the small bowel wall.
But the procedural details for acquiring a good CTE are specific. You can't just check a box for a routine CT. The paper emphasizes the necessity of a multi-phase technique. You need an arterial phase, followed by an enteric or portal venous phase. Why is that dual-phase approach so critical?
Because you're hunting for different flow dynamics. The arterial phase is designed to catch that active jet of extravasation or the bright arterial blush of an AVM. But the enteric phase, which is slightly delayed, is necessary to catch the venous pooling of a slower bleed or the mural enhancement of an inflammatory lesion or tumor that just takes a little longer to light up.
Okay, and the other piece of the CTE protocol that I found fascinating is the oral contrast. You have to use neutral oral contrast. Using positive oral contrast, like the bright white barium or iodine-based drinks we often give, is a mistake here.
If you use positive oral contrast, the bright contrast in the bowel lumen will completely obscure the bright iodine contrast leaking from the bleeding vessel.
Right, you blind yourself.
Exactly. Most small bowel pathologies that cause bleeding will hyper-enhance after you give IV contrast. By filling the bowel with a large volume of neutral contrast like water or a PEG solution, you distend the lumen and create a dark, low-density background. That makes those hyper-enhancing vascular lesions pop off the screen.
This brings up a really interesting guideline refinement regarding capsule endoscopy. For years, the pill camera has been the go-to first-line test for obscure small bowel bleeding. But Sengupta and colleagues state that CTE is now the preferred first-line imaging over capsule endoscopy, specifically in patients at risk of capsule retention.
As a crucial triaging point, if your patient has a history of Crohn's disease, known strictures, or a history of prior abdominal surgery that might cause adhesions, you do not want to risk a pill camera getting lodged and causing an obstruction. You bypass the capsule and go straight to CTE.
Yeah, and CTE is also elevated as the preferred first-line test if a small bowel neoplasm is suspected. The paper includes some visual evidence for this. If you look at figures 5 and 6, they showcase how CTE excels at finding mural-based masses like gysts.
Oh yeah, the GIST images were great.
Right. A gist often grows exophytically, meaning it grows outward from the bowel wall into the mesentery. A capsule endoscope traveling through the lumen might just see some normal overlying mucosa or maybe a tiny ulceration. It misses the bulk of the tumor entirely. But the multiphase CTE demonstrates that large exophytic vascular mass extending outward.
It gives you the full transmural picture, which is exactly what the surgical or IR team needs to plan their approach.
Let's briefly touch on upper GI bleeding before we get into the interventional techniques. We'll keep this tight because the core rules here haven't fundamentally changed. EGD upper endoscopy remains the absolute gold standard for non-variceal upper gastrointestinal bleeding. You resuscitate, you stabilize, and you scope.
Precisely. For the pathways we're discussing, catheter angiography only enters the upper GI algorithm as an adjunct. IR steps in when the endoscopist fails to achieve hemostasis, when bleeding recurs after endoscopic treatment, or, when the patient has postoperative anatomy like a Roux-en-Y that physically prevents the scope from reaching the bleeding site in the bypass stomach or duodenum.
There is a remarkably simple but effective procedural pearl in Figure 7 of the Singupta paper for this scenario. If the endoscopist visualizes a bleeding ulcer, but they just can't achieve durable hemostasis with epi injections or cautery, they should place an endoscopic clip directly adjacent to the lesion before they withdraw the scope.
Yes. Look.
When that patient rolls into the IR suite, that tiny metal clip acts as a fluoroscopic roadmap. X marks the spot. It reduces the amount of contrast the IR physician has to use, and it cuts down procedural time doing embolization because they know which branch to select.
It is an example of how multidisciplinary coordination saves bowel and saves lives, and that coordination transitions us perfectly into the cath lab reality. Let's say you've identified active extravasation on your CTA, or you have your endoscopic clip. The patient is on the table. How should the IR physician approach the embolization to maximize hemostasis while preserving the health of the bowel?
So access is typically common femoral or left radial. You navigate the aorta, you select the SMA or IMA based on your CTA roadmap, and you perform your angiogram to confirm extravasation. But the golden rule here is selective catheterization of the end vessel. You must advance your microcatheter deep into the specific vasa recta, supplying the area of bleeding.
And the reason for that strict anatomical rule comes down to collateral circulation, or, well, rather the complete lack of it at that distal level.
Right.
If you're embolizing proximally, say near the marginal artery of Drummond, the bowel might survive because there's a rich network of collateral vessels providing backup flow. But once you navigate down into the vasa recta, you're dealing with terminal branches.
Right.
There is no collateral supply to that specific centimeter of bowel wall. If you occlude it completely and permanently, that segment of bowel dies.
Which makes your choice of embolic agent highly consequential. I really want to highlight a striking data point from the consensus paper regarding severe bowel ischemia. If you're ever discussing protocols with your surgical colleagues, this is the statistic to quote.
Oh, absolutely.
The rate of severe bowel ischemia was 5.3%. That's 3 out of 56 patients. When particle embolization, with or without coils, was used. Compare that to an absolute 0%, 0 out of 66 patients when coils alone were used.
It is a profound difference in outcomes. Particles, by their physical nature, flow distally with the bloodstream. Even with a perfect superselective microcatheter position, those tiny particles can wash forward and wedge deep into the intramural capillary bed of the bowel wall itself. That causes irreversible transmural necrosis. Microcoils, on the other hand, provide highly targeted mechanical occlusion right at the bleeding site within the vasa recta. They drop the perfusion pressure just enough to allow the body's natural hemostasis to take over, but they preserve enough of the microvascular flow in the capillary bed to prevent necrosis.
What about liquid embolics? Because I know glue is gaining traction for lower GI bleeds.
Yeah, glue is highly effective, and the data actually suggests it has a lower rebleed rate than microcoils in certain settings. However, because it's a liquid that polymerizes upon contact with blood, it flows before it sets, so it carries a slightly higher risk of bowel ischemia compared to coils alone. It's still much safer than particles if deployed correctly by an experienced operator, but coils remain the safest profile for bowel preservation.
So the takeaway for the cath lab protocol is clear. Targeted, extravasation-confirmed embolization with coils is paramount. Blind embolization of a wider vascular territory based on a vague suspicion without seeing active extravasation on your run is no longer defensible. The ischemia risk to the patient is simply too high.
Right, but that naturally leads us to the nightmare scenario. What do you do when the patient is bleeding out, your CTA is negative, the RBC scan is negative, repeated endoscopies are negative, but the hemoglobin just keeps dropping?
You're looking at a patient who is transfusion dependent, constantly in and out of the hospital, and running out of standard options. That's when you consider the ultimate break glass option, provocative mesenteric angiography. And to understand its role today, we're bringing in the 22-year retrospective data from Duke, published by Benvenuti and colleagues in 2025.
This gives us the largest, most modern data set we have on provocative mesenteric angiography, covering 119 procedures. And the core concept of provocative mesenteric angiography is you are intentionally overriding the body's hemostatic mechanisms to unmask the bleeding site while you have a catheter in place ready to embolize. You are medically inducing the bleed.
Yeah, and the procedural details and pharmacologic dosing have evolved significantly. Historically, agents like urokinase or streptokinase were used, but those carried systemic bleeding risks. The modern Duke protocol relies on TPA infused into the mesenteric circulation, paired with heparin and sometimes vasodilators to increase flow. And over the last 2 decades, their TPA dosing has actually escalated. They now start at 10 milligrams and escalate up to 20 milligrams, delivered in 2 to 3 aliquots.
I know to a lot of clinicians, the idea of pushing 20 milligrams of TPA directly into the mesenteric artery of a patient with a known history of GI bleeding sounds terrifying.
Right. Sounds like a guaranteed setup for a hemorrhagic stroke or just a catastrophic systemic bleeding event. How is that safe?
Well, it all comes down to pharmacokinetics and venous anatomy. First, TPA has a very short half-life of roughly 5 minutes. But more importantly, consider the venous drainage. When you infuse TPA into the SMA or IMA, that venous return drains into the superior or inferior mesenteric veins, which join the splenic vein to form the portal venous system.
Ah, so it goes straight to the liver.
Exactly. The TPA is delivered to the liver. It undergoes first-pass hepatic metabolism. The liver essentially chews up and clears the fibrinolytic before it can reach the systemic venous circulation to travel to the lungs or the brain. So you get this localized fibrinolytic effect from the bowel wall to unmask the bleed with little systemic effect.
And the safety profile in the Duke data backs that up. Despite using fibrinolytics and heparin, there were 0 major hemorrhagic adverse events across all 119 procedures. They only had 3 minor self-limited access site hematomas. It is a remarkable physiological workaround. But safety aside, I want to challenge the efficacy of this procedure based on this modern data. If we look at older, pooled, systematic reviews of provocative mesenteric angiography from decades ago, they often cite a positivity rate of around 48%. But in this 2025 Duke cohort, the overall positivity rate of provocative mesenteric angiography dropped to only 27.7%. You are subjecting a patient to a complex, multi-hour arterial procedure, and you're only finding the bleed about a quarter of the time. Why such a drop-off? Are we just doing this out of desperation?
No, it's a classic case of selection bias, driven by the evolution of our other imaging modalities. Think about it. 20 years ago, CTA was not nearly as sensitive. Today, modern multi-phase CTA and CTE are catching the vast majority of subtle, intermittent bleeds before the patient ever reaches the point of needing a provocative study in the cath lab. The patients left over for provocative mesenteric angiography in 2025 are the absolute hardest, most obscure cases. They are the needle in the haystack of the haystack.
Which means patient selection for provocative mesenteric angiography is everything. You cannot offer this to anyone with a dropping hemoglobin and obscure bleeding. The most actionable pearl from the entire Duke dataset is clearly defining who not to treat.
Yes, their subgroup analysis on presentation symptoms is definitive.
Right. 0 out of 11 patients who presented with obscure melena and had negative prior radiologic studies had a positive provocative angiogram. 0.
Yeah, I would advise anyone mapping out a protocol. Do not offer this high-risk, time-consuming procedure to that specific low-yield subgroup. If the patient presents with melena, which indicates a slower, more proximal bleed that has had time to digest, and their CTA is negative, stop. Provocative angiography will not help them. The success of provocative mesenteric angiography is heavily predicted by 2 factors: the clinical presence of hematochezia, meaning brisk, active lower GI bleeding, and a prior positive radiologic study, like a CTA or RBC scan that caught a bleed in the past but is currently negative. If they have those predictors, the 27% yield justifies the procedure. If they don't, you are just wasting contrast, radiation, and the patient's time.
Well said.
And as we look toward the horizon of this field, while TPA and heparin remain the standard for provocative angiography, there's a shift starting to occur. Sparse but emerging data suggests that CO2 angiography might be the next evolution in unmasking these obscure bleeds. CO2 acts as a potent vasodilator, and because its viscosity is hundreds of times lower than liquid contrast, it easily extravasates at the site of mucosal injury. Early reports are showing higher success rates between 48 and 79%, with excellent safety due to the rapid reabsorption of the gas into the bloodstream.
If you take away one specific change for your practice tomorrow, it is to stop offering provocative mesenteric angiography to patients presenting with obscure melena and all negative prior imaging, as the diagnostic yield is effectively 0.
Also, let's say, tomorrow, if you were treating an acute lower GI bleed with catheter angiography, you might consider strictly utilizing coils over particles to drive your severe bowel ischemia risk down.
To definitively solidify these imaging pathways, we would need a large-scale randomized controlled trial directly comparing CTA against SPECT-CT tagged RBC scans in borderline stable patients to settle the localization accuracy debate once and for all.
Rusty Hofmann here, great pod and great work by the authors. One thing that I think is important when you talk about doing diagnostic angiography in the GI tract is a couple of pro tips. One, give glucagon. It will paralyze the bowel and stop bowel peristalsis so you don't get digital subtraction artifact. And number two, make sure you inject long and sustained. You don't want to do SMA run for like 5 for 20. Like I'll do it 5 for 35 or 5 for 45. And you know that your injecting rate is too high if it's starting to reflux into the aorta. And if it's not, you can always go up. And one other thing that we're seeing at Stanford is our patients are older and sicker, especially with this GI bleed population. In really tough cases, we're also requiring that the patient has general anesthesia so that we can suspend breathing in order to find the bleed and then treat it adequately. One other pro tip on GI bleeding patients: it's been my experience and that of others, at least at our center, including with trauma patients, is you really don't see active extravasation unless the patient is hemodynamically unstable. So I keep it simple: systolic blood pressure below 100, a pulse above 100, or on pressors or actively getting transfused. This is Dr. Rusty Hofmann, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.